In this conversation with Dr. Gregg Gascon, data science advisor at Ohio Health, we explore how AI is being applied in real world healthcare settings. Dr. Gascon shares how Ohio Health operationalizes AI at scale, running models that generate over 800,000 predictions daily, from patient deterioration to fall risk. But success isn't just about algorithms, it's about workflow, human behavior, and system design. We also discuss the use of generative AI for clinical documentation, helping reduce physician burnout, and the importance of culture, training, and continuous improvement. For aspiring professionals, the message is clear: master statistics, stay curious, build strong networks, and remain humble in a rapidly evolving field. Hello, welcome all. I am Pavan Mirla. Today we have a guest, Dr. Gregg Gascon. Greg is a data science advisor at Ohio Health, facilitating artificial intelligence implementation, evaluation, and optimization. Dr. Gascon is an assistant adjunct professor of biomedical informatics in the Ohio State University's College of Medicine and serves on the American Statistical Association's Public Affairs Committee and the International AI in Medical Education Working Group at University of Toronto. Welcome, Dr. Gasson. Today, we would want to hear from you about the industry you work in, your role, and what advice you have for someone interested in healthcare and AI.
Yeah, thank you. Thank you. Well, as you've said, my main focus is healthcare, and I have worked in Ohio Health since 2017. And at first, they brought me over from OSU or Ohio State University to do health intervention evaluations. So if the system was putting out a diabetes prevention program or another type of a condition treatment program, I'd be brought in as a PI to do the evaluation work to identify whether or not it worked. And so it involved understanding a great deal about the nature of the disease, how the individual interacts with the healthcare system, and how that healthcare system can support them in getting better, optimizing their health really at any point. The funny thing is when you think about healthcare as an intervention, it's only a single point really in the life of a person. They're not there every day. You're not under continuous monitoring. So the interventions have to be strong and stay with the individual for a while. And then there's a lag. So if you create a wellness program, it might be 3 years before you see any type of an impact on the individual. Research design, the appropriate statistical model, understanding the context of the care, all of that matters in a healthcare intervention. Then, as Ohio Health started moving into AI, they put my group into that same operational milieu, but just with AI models. So the thinking was AI is an intervention in a healthcare area that is premised upon a known and measured problem with a target state in mind. So everything fell into place from that, really, as to how it all evolved. But as I say, it's not as if in this particular case the AI was perceived as something different than something that could be offered by a healthcare system to hit one of the quadruple aims in that regard.
So, who is using your research?
So we have two groups currently within data science. Our program is evolving. We have a CIO that is reorganizing the work on the pillars of analytic insights, AI, data engineering, and actually there is a fourth component dealing with just the optimization of the electronic health record. With that setting in mind, we're working the gamut. The interesting thing about it is almost all AI interventions take place on the basis of the electronic health record, and EHRs were not prominent I think the big spark was the High Tech Act that pushed it forward in the last decade. But in any case, AI works off of assessments that are made by clinicians in operational and clinical roles, and that data gets pulled into an AI algorithm in order to make predictions, and those predictions are then acted upon by clinicians in the midst of a complex adaptive environment within a socio-technical space. So, Luciano Floridi is the most prominent AI ethicist that I'm aware of. He wrote the Tetrarchy of the Philosophy of Information, and he wrote that AI is a third order technology in that it interacts with other technologies and the human. So, where you put the signal matters a great deal. So, human factors research is prominent in AI. We used to call it human computer interface back in the 70s. And it's really evolved since then to really understand how these things go. So, you might have a predictive model that's developed by engineers. Then it goes to a team of us that work on enabling it into that environment. So there is a AI enablement team at Ohio Health that handles the intake. So the intake process is a bit like knowing that you have a problem and being able to measure it, saying relative to national standards our treatment of this particular condition is, at a certain percentile. So if they want to get better, we have to first determine, have you put in all quality improvement ideas that have been out in the environment? So is this a diffusion problem where a solution exists? We just haven't implemented it. And once you go through that, then you're trying to figure out what's actually going on. So workflow analyses become vital. At Ohio State, we called them industrial engineers, and they would go through the workflow and follow the doctors and nurses throughout their day, see how they interacted with the electronic health record, see how orders go, where labs and imaging were, and then identify how to improve the efficiency across the workflow by getting to problems quicker. So one of my students did fantastic work in developing a machine learning model that detected acute pancreatitis quicker. And as a physician, he was able to take a look at the entire process of diagnosis when the patient presents at the ED, which is really important because in your head, you've always got to remember you're in an environment where there's people are having the worst day of their lives all around you and you have to act as quickly and professionally as possible to assist that individual in the midst of all the as I said the human drama around you. So what he did is he reduced the cognitive portion of it to thinking what steps could be taken to eliminate competing steps so that I am constantly disproving hypotheses as I move forward in my analytic chain of thinking. And that really encapsulates how the engineers do that type of work, figuring that stuff out within within the enablement space or if we think about the AI life cycle within the planning function as we move towards documentation, we're trying to take what we know about the model and the context and then document as much as we can about how it's taken care of. And typically we've thought about inpatient settings, but it's ambulatory as well. I think 70% of the work that's done, the patient encounters are happening in the ambulatory space. So that's different for a number of different reasons. But that whole process of understanding the way that the human interacts with the technology is part of our work as research scientists that support engineering, that support AI enablement, and are speaking with leadership about what they want to see and speaking with the chairs of service lines and saying, what are the most important factors that we can deliver that'll deliver the most value to the greatest number of people. Really trying to figure out all those things. And so it's a lot of communication, organization, reading loads and loads of studies. I know at Ohio State, we always had 8-foot tables and we'd stack up our projects like histograms, and there'd just be books and papers all over, depending on what you were working on. But it was
Mhm.
very helpful because you'd always have colleagues popping by and posing really, really great questions that kind of spur your thinking along. And
Mhm.
so, yeah, we really benefit from diversity in that sense,
Mhm.
where the greater the number of experiences that you have on your team,
Mhm.
the better off your team is. And I'm thinking of one particular person that we work in on the team, and she'll always speak up by saying, here's what I've seen and known in this particular context. And
Mhm.
that leads a lot of us to say, I've seen something similar to that. What would work would be another. And we have another person that'll talk about different industries. Well, here's how different industries would have approached that problem. And you're like, okay. And then you always have a historian in the group that say, when it came, and it really doesn't matter how you came about it. We were talking about frontier medicine at one point because we were trying to figure out how to shrink the gap of space when you have rural hospital closures. So what can you do to decrease that space? It's like a Mary Breckinridge problem now. So now you're trying to think, well, how can we reduce space? And
Mhm.
the Canadians have a terrific air ambulance service that we've learned a lot from. So thinking about those problems, that's what I mean.
Mhm.
There's just so many issues in healthcare to address.
Mhm.
You have to be widely read and and in touch with a lot of different people with a lot of experiences. Those groups, the ones that are talkative, are the best ones to get into where folks are there. And that goes back to another thing is that the organization that you operate in is vital. At Ohio Health, our leadership looked into high reliability organizing, a way of working that reduces error by putting certain things in place, like a culture of safety, psychological safety, so that everybody feels free speaking up, all with an emphasis on error reduction, with a constant thought of how can we reduce errors? How can we improve our service? We worked with some surgeons some time ago, and they only went by their first name. And I asked them, why is that? And they're like, well, we don't want anything to get in between us and our technicians and nurses when it comes to taking care of it. But we want them to throw the red flag, say, no, something is not right here. We need to stop at this point. And
Mhm.
HRO really embodies that. And it also offers a set of learnings for everyone to understand
Mhm.
what it takes to reduce errors
Mhm.
in this medical setting. There was several books that were written for the U.S. That were written about error reduction, and I think that spurred on the HRO movement and psychological safety. But if you're lucky enough to operate in those environments, then a lot of this stuff becomes very free because you can have very candid conversations about things that you see in the Gemba. We go from that conversation. The Gemba is just the workplace, place where work gets done.
Mhm.
We've been a part of a number of different quality improvement management cycles and ways of understanding things. And several of them, they just stay with you as you move through. But there's nothing that can make up for being in the work setting. Because
Mhm.
I think remote work is difficult in that instance for data scientists because you don't get that chance to interact with operators.
Mhm.
In our world, operators are everything because and they're very, very blunt. They'll tell you when something's not going to work, when a
Mhm.
signal is too weak, when you have to pull out of the EHR and go to a separate database to check something. That yeah, there's no making up for that type of time. And like I said, the other thing you get when you're working in that environment is the ability to talk to folks and see what they've seen about that stuff. But really
Mhm.
that's a lot about the Gemba. But I did want to say um, for your viewers that there are some great AI programs out there that offer post-secondary education in the field. But most of the people that I work with didn't go to school for their PhD in AI because it simply wasn't available at the time. So most of the people I work with have degrees in all different types of fields, and I think that's really really helpful. Because as I say, you're bringing all those different perspectives into play, and it's crazy that even we just finished writing a book, Anthony Chang and Alfonso Limon, and I had put together a textbook on AI in medicine, and it was crazy because Anthony would say, I just need another week. Something new has come out. And every single week that went past, Anthony was saying there's a really big breakthrough in this other area. And I was just like, oh my gosh, AI is the most rapidly progressing field that I can think of. It's like biochemistry at one point in the 90s, moving so fast.
Yeah,
Yeah.
I see. Yeah, thanks very much for sharing those insights. Since I work in finance, I see major difference. Though the tools are the same, in finance, sometimes it's okay to work in silos.
Yes. Yes.
You work based on your expertise, understanding of the markets. But in this context of healthcare, it's the understanding of the circumstances is important. You need to be present in the situation, hear multiple perspectives, and improve over time. I see more the human element there.
Yes. That is true. But what's interesting is in finance, you're following either the rules of FASB or GASB in the United States. You have two set of accounting rules that you're working with. In AI, there's a number of competing frameworks. I read an article the other day that said that they could trace back 200 ethical frameworks that countries have put out. Even within the United States, California has its set of laws that's different than the federal set of laws. So, one of our jobs is figuring out which framework to apply. And for us, it's been NIST. NIST's 600-1 and its component for generative AI provide you with a risk management framework to understand the particular vulnerabilities of either prognostic or predictive models and generative AI. And I believe they're working on an agentic piece now. But that's another thing is that when you speak with colleagues from different systems, and even more so from different countries, everybody has a different framework involved. We were on the phone. I'm on the American Board for Artificial Intelligence in Medicine, and it has an office hours on a weekly basis that's international. And we had a physician, a MD, PhD from Australia that was talking about the legal context of dictating notes in the midst of a conversation about ambient AI that was just fascinating. And his whole the way that he approached the problem was shaped by the legal framework of the country he was operating in. So I don't think we take that into account as much as we should be. I work a lot with T. Karam from the University of Toronto, and their perspective on healthcare is very different because of their series of frameworks and laws. So there's a movement to try to understand where everybody else is at in the world on a lot of these issues and try to come to an understanding of how we can optimize them across the way. And like I said, Luciano works in a lot of different environments where he speaks on these issues, and he
Mhm.
ties them together through an ethical framework within the context of philosophy, which is always fascinating. But each country has its own AI legal scholars, which I think is wonderful because when you get talking with these folks and you read their papers, their vision of what AI can do for the patient is shaped by that legal and almost social environment that they find themselves in. I think each country's taken a different perspective on what AI can do or should do, and that's shaped out like that. But getting back to silos, I think everybody on our team is a specialist in their own area. But when we come together, that's when you start exchanging those ideas. Um, and almost every single meeting goes over time, which is always a good sign to me. I can bake it into the schedule so that I understand we're going to go over because folks are still talking and exchanging ideas. It's always a nice little measurement during the day as to whether or not things are going well on the team is to see that level of conversation and interaction. Because as I said, with psychological safety, people feel free. I worked for a great fella, Phil Taylor. He always would say, boys, put the skunk on the table. All he wanted to know is what was going wrong and in an honest as way as possible so that he and his colleagues could address that problem. And in the back of my head, I always hear him saying that because what you're trying to do is surface as much knowledge as you can so that people from different perspectives can see where their skill set can address one of those challenges to overcome it and adapt it for the system. And that's another thing. AI has changed. When we first started out with AI, it was thought to be run by project managers. So it was very IT, fail first framework. And how it's evolved over time is people appreciate that AI has a life cycle now. So there's a great understanding that AI is for product managers rather than project managers. And as a product, you're managing it throughout several different iterations of use cases. And in our world, different types of service lines, different types of physicians and clinicians in different hospitals. So, how does the model interact with their context? Are you going to change thresholds? Are you just going to change the BPA so that doctors are attending to a different signal? I think that evolution has been fantastic. We worked with Unity up in Ontario province, and they were at the level, I think, at that time of putting 30 AI models into clinical workflows. And when you talk with their staff, they said that, it's a real challenge. Some of the models are going to give signals on the very same patient. So you've got to think about how does the clinician react in that? And so rather than a multiplicity of models, they're trying to think of the fewest models that you can operate so that the physician is aided by all of those signals and not inundated by all of those signals. And they talked really nicely about how data science teams shift into maintenance teams because after a while, your models are operating every day. In our system, I have 14 models and they have over 800,000 scores per day. So I can see how those models are working in real time. And when we pull the external validation data, that's giving us one. When I go to the Gemba, talk to the physicians about it, they're giving me a different view. You can spend all day long, all year long, just getting signals about the way that the models are working in practice before you even pull back and go back to the quality and patient safety folks and say, how are we doing with stroke care? We had a large vessel occlusion detection program in one of our hospitals in a spoke and hub system. And it was fascinating to see how times changed with the introduction of AI in that environment. And a lot of the doctors, once you reach that point at which you've hit your benchmark, are saying, what's next? How do we move further? And that's sometimes a combination of rethinking work processes. And that's really where AI gets fun because they're like, with AI, we can actually change clinical workflows. We can do different than we have done before to optimize care for patients. And at that level of creativity, that's really where you want to be in that space. It's so exciting to see what's possible about redesigning care around the patient's experience. Because again, the patient is episodic. Their encounter is a one-off. They're coming in, they're leaving the system. Once they're gone, that's it. And we've worked with different types of patient monitoring system, and that's a fascinating side of work that I wish I did more on, where you have a patient with heart failure and you're able to monitor them in real time so that they never feel alone. They're always connected to the hospital and the care.
I see. I
Like I
see.
said, I could talk about this all the time because really the data science is all about the improvement of life for folks. At the end of the day, you're when we're in the if we're in the hospital, as I said, you're meeting people on the worst day of their life. So how do you how do you make it the most comforting environment, the most respectful? How can you provide all the data to the clinician so that they can make better decisions in real time? So you're part of that whole care team, in other words. So it's
Exactly.
and
It,
that is different than finance, Pavan, because with finance, oftentimes the AI is utilized to support a decision. And I don't know if you get into how the individual receives the wisdom from that decision, but that's one thing different about healthcare. You can actually see how the patient's lives are changed through those different interactions.
yeah. So
Um,
you can immediately see how applicable it is. We learn quick instantly.
yeah,
So
yeah.
could you talk about the models you mentioned? Say 30 models in Toronto and 14 models at a very broad level. So are these classification models or generative models? Could you give me broad categories of these models?
Yeah, I only work with three generative AI models, and those are very different. Those were developed in order to speed up documentation. So, what I've seen is that they're not universally well adopted. Adoption tends to be for specific use cases. So it's similar to diffusion research, where you statistically you're pulling in data of users divided by eligibles, and then you're classifying them in the most appropriate way, like where are we seeing the greatest utilization by department, by location, and then you're going out to those places and saying, how are you using? I'm seeing that there's a lot of information that's being transmitted about the use, but what I want to understand is what are you using it for? And they'll come up with things, the developers had never thought of ways that they're using it to improve documentation throughout the day. There's a measurement that we have in the system called pajama time, where we're looking for documentation that occurs off of established hours. So with this documentation, pajama time shrinks. So one of the docs, we're working on an ambient AI solution. One of the docs told me for my evaluation, I should call her husband, because she was saying the biggest benefit to her is that she doesn't have to be working once she gets home continuously throughout the night, that she can do all the documentation much better in that arena. So that's one ambient model and the three Gen AI models. And we have other models that classify patients into risk categories. And what I always find interesting, because I studied measurement in school, was those people right at the cusp. So in a prognostic model, you have people that are at a cut score or above. But one thing we found when I was still in school is there was always turbulence around the cut point. So understanding the arc of risk is vital when you're looking through the numbers as to who ends up in what category or classification. One doc put it very well to me that the risk categories allowed her to see insights into how risk was changing over time. So we have a model that looks at clinical deterioration, and if a patient's on oxygen, if a person has advanced age, they're going to naturally be categorized into a higher level of risk because even though the person doesn't have a higher probability of mortality on that particular day in general, when compared to other people, they're going to have higher risk, depending on a lot of their different factors. These models might take 125 variables that they're working through and give us a new prediction every 15 minutes. So those classification variables, even though they are static buckets that people are put into,
Mhm.
they change over time.
Yeah.
So one of our hospitalists had come up with an idea of tracking changes in scores. Um, uh, we picked up the phone. We called another hospital that was working with a model like that, and they were telling us that a jump in a score from a yellow to a red of 10 points or more might be more meaningful than knowing that a person was in a particular category. So my colleague, Dr. Vicky Zygmunt, she ran a statistical study to look at how risk changed over time, and it really shaped the way that we saw where there was opportunities to intervene for these patients. So I think again, when you're thinking about the patient and their family, and you're thinking about how risk changes, what you want to know is when should a clinician spend more time looking at that? And one of our great times during the day is shift change. At shift change, when you do the handoff, you can say, here are the risk scores for this individual. Here's how they're operating. And it gives that other person, the recipient of the information, a great deal of information about how they can better understand the patient's condition, because a lot of assessments, and this goes back to the electronic health record. Remember, all AI models to some extent depend upon the assessment data that's in the EHR. So at Ohio Health, we have a committee that works with the EHR to understand how to optimize these. One of the assessments we were using was a particular fall risk scale, and when we did our due diligence on the documentation side of the AI life cycle for a predictive model for falls, the nurses spoke out and said that they had a concern that the pharmaceutical categories that were being utilized inside of that assessment were dated. And when you think back, when you and I were kids, there weren't half as many as drugs or even classifications. So her point was, let's take a look and see what's better. So nursing leadership translated that into a request that we do a clinometric comparison. So let's take a look at all the fall risk assessments that are available. Then let's look at those that are available that we can put into the EHR, and then we'll take the next step. So we did a year-long study with, I think, over 100 nurses after we did the clinometric comparison. So the clinometric comparisons, when you just look in the literature and you look at reliability and validity and how those assessments stack up, then you move it into where you actually work with the nursing leadership to take those assessments out and say, here's two paper forms. Let's look at the fall risk assessment of patient A using these two forms. And we do it. We had ersatz patients. We had them live at some point. All the data that we were collecting was, what's the cognitive load on the nurse when doing the assessment, and which one are they finding provides them with better information. So after that second study, both of them were approved by the IRB, and that's a big emphasis for me. Is we use our IRB the way that they're meant to be, to tell us where we need to be careful about patient risk, and also to guide some of our thinking and get into those conversations about what's the best way to go forward about protecting patients and their rights. So after those two IRB approved studies, we came up with a winner, and we presented it to system leadership. And now we're putting it into 16 hospitals. And at each hospital, we're going back and we're doing asynchronous training. So we have the videos that are available anytime. We'll come also to the facility and do the training. And then we're actually calibrating nurses. So this is something that is not commonly understood in AI, but when you have an assessment that gives rise to an algorithm's input, you're assuming that every clinician is doing it the same. They don't. Every clinician is going to look at a patient and judge them according to their education, their training, and all of their experiences. And we work with brand new nurses and 30-year nurses to really understand what are those different factors. So we take 9 case studies when we do our training, and we ask the nurses to use the new assessment, rate the risk of the individual. Then we look at it category by category. Our lead explains her reasoning as to why she would have scored this, then she's now the gold standard, and we're working off of that. And the nurses have a conversation about, well, this is what I've done in the past. Fascinating stuff to calibrate, folks, so that they're all on the same page. And as I said, now we feel much better about our fall risk. And I just pulled the numbers, and our fall risk per 1,000 patient days is going in the right direction. Really, really nice study. But like I said, that's usually not what you think of when you think of the AI. People usually think I'm going to develop a model, it's going to offer a prediction, and that's it. When it's really interactions between everybody that's around the patient, the electronic health record, the platform that it provides you with, and then all the data that goes in. I mean, just when you think about it, if you're getting a prediction every 15 minutes, that means you must be getting new data from somewhere. So what does that new data look like? When you're actually in the hospital, you'll see patients take off the portable cuff because they'll say it's irritating their skin, so they'll put it down. Now we got zeros on our model, right? It's malfunctioning. We've got an alert. It's all of those human factors, like I said, that goes into understanding how you optimize healthcare using AI as one tool out of many. One tool out of many.
Do you use multimodal AI? Say, for documentation, we would use LLMs for
Yeah.
text.
Yeah.
So, do you have any models for audio, even analyzing camera feeds?
We don't at this time, but one of my colleagues has started looking at that. Uh, we wrote a paper with folks from TCARM on multimodal data to say, here's what we would like to use. But we're still in the situation where we have not put all of those together for the right use case. There's several that I can think of, and like I said, we advanced one for the paper, but where we're at right now is perfecting machine learning interventions into the clinical space. There's a article by Rand. Rand found, I believe, that only 20% of models that are put into clinical workflows are successful. And it's so we have a new book that we're in contract with Elsevier on that looks at applied implementation science for machine learning in clinical workflows, where you just start to break down human factors, human error, systems thinking, learning health systems, diagnostic methods for understanding clinical systems, and then uh, I mean, my goodness, then you're really off to the races about how you combine all of those things to understand how to do that one function. Where I would see multimodal is at more of a laboratory space right now to see what data that you have. My team's not done it, but I'm certain that teams have put together multimodal models into clinical workflows. It's just with our system, I think every system has a strategic plan that they go by. So the way the pillars of our strategic plan are, we're executing on those that have been identified by leadership to address in the near term. Uh, so it's like from a leadership perspective, uh, they're not interested in pushing the science for the sake of science. What they're trying to say is, how do I optimize care at my own facility so that we're operating at a national level of a national standard of care? So we've identified through quality and patient safety and our work with other systems that we have these, 7 priorities, maybe, well, actually probably 5. And so you're working on those. If, like I said, the AI is not the end result, it's a means to an end. So you're using what you have to address those challenges. I think that's very different too. Ohio Health, is a community health system. We're operating 16 hospitals in 50 counties in Ohio. We're not an academic medical center where we're doing proof of concept and advancing particular ideas about ways that care can go. We're taking the ideas that have been advanced already by like the National Academy of Medicine uh, and other organizations to understand what our patients need to optimize their health and where our healthcare systems are at relative to that care. So in that sense, it really is, it's more like quality improvement. But to me, quality improvement is when you're not certain of the intervention. So you're in an experimental mode,
Mhm.
plan, do, study, act. Whereas we tend to use CFIR, the Consolidated Framework for Implementation Research. CFIR advances from a model intervention that's already been shown to work in randomized controlled trials. So you've already done the science, now you're implementing it. And I think that's where academic centers and community hospitals can really work together
Mhm.
because it's part of that whole cycle.
Mhm.
Like I said, the interest is improvement,
I have learned so much from this conversation. There is so much that could be taken as inspiration from healthcare to finance because multiple perspectives and more empathy towards the patient, the clinicians, the nurses. We need to consider everybody's interest, everybody's role, because at the end, you got to collect everything and reinforce, improve the model, the goal being to reduce the errors. So, to pursue a career or to get into this domain, what sort of skill set do you recommend?
uh the first thing I'd say, not flippantly, would be that you have to love reading. um I'm sure somebody will tell me that there's a correct figure, but the last time I remember looking it up, there was more than 20,000 articles published a year, in general in medicine. And I'm sure the figure is much larger than that now. But your ability to first, you have to love to read in order to be in this field, because there's so much to learn. If and if I ever meet people that are confident that they know everything, I know that I should avoid them, because the most of the people that I've met, 99.9% in this field, are very, very humble individuals who realize how much that they don't know.
Mhm.
So they need to be reading and talking with people and experiencing other healthcare systems and going out and working with them. So the first thing is reading. Second is a network. So the American Board for Artificial Intelligence in Medicine was put together by Anthony Chang and Robert Hoyt and colleagues several years ago to bring physicians with data science experience together to widen the number of people who know both fields. So they offer training courses. You can sign up for their training course. He had a textbook years ago, 2020, I believe. We used Ted Shortlift's book at Ohio State when I taught biomedical informatics, and it was a very large book. But each of these books are getting so large now. We have a lot of books now that are just digital because the AI is progressing so rapidly. But ABAIM offers courses. TCARM at the University of Toronto offers courses. Those I found to be most helpful. I'm a traditionalist. I buy the book, I flag the pages and read them. Anthony Chang, ABAIM, he keeps a list of seminal articles per field that's available to folks that go to office hours. So if you need to know about any particular subject, he's already gone through the literature to show you where he's at, and he's really smart about taking different individuals that have provided information on free sources like YouTube, and he'll link to them. So he'll say, if you go to this site, you can learn about deep learning even better than reading through 4 or 5 articles, because they're going to show you this in real time. So I found his style to be wonderful in that regard. We have a fellow at Ohio State, our chief research informatics officer, that thinks the same way. That a 10-minute segment to introduce you to a topic, and then targeted readings of seminal works are sufficient to get you into a conversation where then you can speak with people doing the work and understand and even better. The other thing you really need is a thorough grounding in statistics. It's like I'm saying that as a member of the American Statistical Association, but what I found is that the ability to think like a statistician about variability, about causation, helps you a great deal in AI, and I think the two are naturally cousins when it comes to how you put this work together. So that's been very helpful.
I see.
And the other thing is uh, ask someone that you know. So I went for my PhD years ago, but at the time, Edward Tufte uh, was the biggest name that I knew in statistics because I had his books and followed him. And so I wrote him a letter and expressed I was going into the quantitative sciences, want to get his his opinion, and he actually uh, uh, wrote me back and provided a bibliography,
Mhm.
and he told me where to start, and there were several textbooks before I got to the bottom. So I started reading them one down to the other, and it introduced me to the world that he occupied, and that was the most helpful advice he ever gave. John Tukey was on that list, and Fred Mosteller. And when I finally started going for my PhD with at Ohio State, I had the opportunity to ask Fred to come out to Ohio State and lead a scientific symposium on experimentation. Fred's the only fella to chair four separate departments at Harvard. Legend. We had a bio statistics conference at the same time he came to our campus to speak, and he was mobbed like a rock star by old men that were just patting him on the back and saying, I was your graduate student in 1982, and all these fellas coming up to kind of pay their respects to this wonderful man who wrote so well. He was the guy that figured out the lost authorship of the Federalist Papers. Unbelievable. He was a Bayesian before it was cool to be a Bayesian. He was, like I said, you just read through his books and they just take you into another world. So that's what I'm glad Anthony's carrying on that tradition. Introduced a lot of people to, here are the best books in the field, here are the best articles. Read through these, get yourself familiar with them, interact with people, and that's what the best kind of networking
Mhm.
is when you reach out to someone who's been in the field a while and just ask for what are the five books you'd recommend, or I only have time to read one book at this time. What should I be reading? Those are the real skills. A lot of things can be taught once you're on the team, but you can't teach desire, uh, and you can't teach a lot of those innate skills like organization. It's a it's not exciting to talk about being organized, but what I notice is some of the most successful people have a way where they start off in the morning, they're writing a list of things that they need to do and how they're going to get those accomplished. They're mindful, they're thinking not of tomorrow, they're only thinking of the next hour. What do they have to do? And by the midday, they're thinking about an assessment of where they are. They plan time to read, and they handle their free time very well by bringing in aspects of their world where you're not really studying the field, but you're experiencing it, and you can understand it better. I always find that to be fascinating too. Just learning from the wonderful people I work with
Mhm.
has been so rewarding.
Mhm. Those are great insights and very relevant for this generation because we have instant answers from ChatGPT. We don't get to spend enough time. We don't want to spend enough time because the answer is there. Now, we are not participating in it. We are just observing it. We're not ingesting it. We are not understanding it.
Yeah, and
So
we're not
reading
reading. Yeah.
definitely has to improve. Even we have to get organized. With all the knowledge floating around us, we need to collect them and curate them over time and learn from it. Greg, it was a pleasure talking with you. We learned so much about the industry. You walked us through your role and how AI is helping in Ohio Health and other contexts. Please send us the links that you mentioned, the University of Toronto and other resources that could benefit a student or a professional looking for a career or something to do with AI in healthcare.
Yes, happy to do so.
Thank you very much, Greg.
Thank you.